It's a pleasure to be here. My thanks to Prithvi and the OMF for the invitation. And what I'm going to talk about today, and I will shorten things at the end because I had been asked to touch on our available clinical trials, but see that that's going to be addressed elsewhere. So what I'm going to talk about, namely, is just the relationship of cutaneous melanoma with uveal melanoma and some of the similarities and key differences that we see. So right now in the US, we'll see about 90,000 cases of invasive cutaneous melanoma, more in men than in women. Many more cases of melanoma in situ that affects the very top layer of the skin, the epidermis, and so it can't get into blood vessels and lymphatic channels, and thus is cured with surgery or other modalities alone. Cutaneous melanoma is now the 5th most common cancer in men and the 6th in women, but what we've seen very alarmingly over the last 30 years or so is a marked increase in cutaneous melanoma in young women born after 1965. So this is a birth cohort effect, and we really are attributing this to tanning bed use and practices which became prevalent in the 1980s and on. This year there'll be about 10,000 deaths from melanoma in the US, almost 2/3 of which will be in men compared to women. We used to attribute this to much of the same factors that Dr. D'Amato was just talking about, where we had worse screening behaviors in men, less apt to go in for a skin check and so on, and thus presenting with deeper, thicker tumors that were more fatal. We have now identified some probable biologic differences as well between tumors in men and women, whether this is related to a more robust immune response in women or even hormonal factors that may play a part. We've seen recent reductions in melanoma deaths in younger age populations, kind of a leveling off of mortality, which has been very useful, but clearly the key factor that contributes to this is early detection of thinner tumors that lack or have a lower potential for metastasis. And so this is data looking at the prior AJCC staging, the 7th edition, which was active as of 2009. We have newer data that basically recapitulates this. If we detect tumors in a stage 1 or stage 0, they tend to be curable, have at least a 95% plus survival. So that's our goal from a behavioral standpoint. We've seen the actual case-based fatality decline over the last half century. So a person who was diagnosed with skin melanoma in 1950 had a 5-year survival of only about 50%. That's all comers with skin melanoma. By 1990, this had increased to 90%. Right now, if we look at all comers with skin melanoma, the 5-year survival is 92%, 10 years, 89%, which is pretty darn good. And this, though, has largely, again, been due to earlier detection of these thinner tumors with lower potential to metastasize. It's only in the last 5 or 6 years that we've had the more improved therapies, much improved therapies, I should say, the targeted therapies and immunotherapies that are now prolonging life and even curing some patients with advanced melanoma. Uveal melanoma, you guys have heard the statistics, a very small percentage of all melanomas, maybe 3 to 5%, much rarer than cutaneous melanoma, and we have different from cutaneous melanoma, seen more of a stable incidence of uveal melanoma with about 4,000 cases globally, as opposed to a dramatically rising incidence that we keep seeing in cutaneous melanoma, which is more sun-related. Uveal melanoma also has about a 30% higher incidence in men than in women. It is seen more commonly in whites of Northern European descent, in the setting of ocular melanocytosis, meaning pigmented lesions in the eye, and in the BAP1 mutation, which we'll hear more about, and there is some cross overlay with cutaneous melanoma or a type of BAPoma type tumor in patients with the BAP1 mutation, though honestly we do not see many patients with both cutaneous and uveal melanoma. How many patients in this audience have skin melanoma in addition to it? Not many, and in 23 years of practice it's a handful and likely more the sun-related type. As Prithvi alluded to, we're not really sure about the relationship of ultraviolet exposure and uveal melanoma. A large meta-analysis looking at the worldwide data has really shown less of a link, though we do see some increased uveal melanoma in individuals who are more sun-sensitive with fair skin and fair eye color. Everyone's probably seen these slides with uveal melanoma affecting the vascular layers of the eye, the choroid underlying the retina, ciliary body, and the iris areas. Very malignant in terms of its potential for local recurrence after eye-sparing surgery, and then of course that risk of metastasis down the line, with at least 50% of patients estimated to metastasize within 15 years of initial diagnosis and treatment. Part of the difficulty in treating the advanced melanomas, of course, is related to the distinct molecular patterns we see in gene mutations and other factors with uveal melanoma, and this has contributed to kind of this treatment resistance. Now, about 15 years ago, we started to think about skin melanoma in different ways, not only the way it presents on the skin, so clinical patterns and histologic patterns, but really how it is related to where it is located on the body, whether the patient has another phenotype looking at moles on their body, whether it's related to intermittent versus chronic sun exposure, and then very importantly, whether there are certain mutations, target or driver mutations, that were evident in various subtypes of melanoma. So what we have seen over time and what's evolved is really looking at skin melanomas as being more truncal, seen in younger age individuals in sites of intermittent intense sun exposure, often in association with larger mole counts, and really characterized by the BRAF mutation. We then have melanomas in more sun-exposed, chronically sun-exposed areas occurring later in life, the head, the neck, the arms, and so on, tending to have fewer BRAF mutations, some NRAS mutations, KIT mutations. We have those that occur on acral sites, palms and soles, not sun-related, beneath the finger and toenails, and those tended to have more KIT mutations, though rates of the KIT mutation have dropped in those, and we see some NRAS mutations as well. Similar findings we see in mucosal melanomas, again, not UV-related, and then, of course, the mutations now in the driving mutations in the G protein and the GNAQ and GNA11 mutations for ocular melanoma, which, again, present challenges for targeted therapy, as we now have very effective drugs that can target the BRAF mutation in particular. So in terms of the clinical heterogeneity of melanoma, what I'm treating are the patients we see with melanoma in non-sun damaged skin, more truncal melanomas, melanomas in sun damaged skin, acral melanomas. Uveal melanomas I do not treat. I'm asked to see these patients for skin screening, and as I said, we see very few patients with concomitant cutaneous melanoma or even an atypical mole pattern. Mucosal melanomas we work with generally our head and neck colleagues, our GI-GU colleagues if these happen to be in the vulvovaginal area, penile area, perianal area. Conjunctival melanoma, how many people in the audience have conjunctival melanoma? I know one whom I've met before at a Melanoma Research Foundation. It's lovely to see you. Conjunctival melanoma, very rare, and we do screen these patients. Conjunctival melanoma may be considered a little more epithelium derived, and I won't pretend to be an expert in that with our group in attendance, but in general, we look at patterns of metastasis with uveal melanoma having more the liver dominant metastasis and conjunctival behaving a little more like cutaneous melanoma, where the lymph nodes, the regional lymph nodes, would be the most common site of metastasis in the parotid, submandibular, and neck regions, wherever the eye is. And so we tend to do sentinel lymph node biopsies for this melanoma, and it does tend to have a better prognosis overall than uveal, but again, a challenge. So we will be looking at these patients. Some idea or concept that maybe having more pigmented lesions, i.e. more moles on the skin, or what we call an atypical mole phenotype, may increase the incidence of having pigmented lesions in the eye, but we've really moved away from the concept that if you have lots of moles, you have a clear-cut increased risk of ocular melanoma. Again, we work together with our ocular oncology colleagues for screening. So what we're left with now in melanoma, I think it's a busy chart. This was developed by Boris Bastian, who's a leader in the field of genomics and molecular classification of tumors, and particularly melanoma. And what Boris has done over his career is really take a look at this integration of ultraviolet exposure, borderline versus malignant lesions, where they are located, and gene mutations. And you can see that when we talk about skin melanoma, these are going to largely be epithelium associated, but we do see some melanomas that are involving other parts of the body that don't per se come from the epithelium. These can be melanomas arising from congenital nevi, or what we call blue nevus. We have a blue nevus-like or malignant melanoma in that situation. Melanocytoma is a very odd lesion as well. The eye melanomas, of course, will fit generally in this non-epithelium associated. Risk factors for melanoma, I don't need to go into in great detail for those of you who've had this. It's generally related to ultraviolet exposure. We see this more commonly in older individuals, men than women, individuals with large numbers of moles on their body, including a phenotype we call a dysplastic or atypical mole, those with extensive sun exposure, blistering sunburns, tanning bed usage, all of this comes into play, as well as strong family history. Melanoma still occurs. This is an ancient picture from the old Thomas Fitzpatrick textbook, and we've tried to update this, my colleague Ellen Geller and I, but it's basically the same. We see melanoma of the skin predominate on the trunk and scalp in men, regardless of whether they have thinning hair. and also on the back and legs in women. And I just want to mention a couple of the common subtypes. It's important to think about if there is a link, if people do have the BAP1 mutation and are increased risk for skin melanoma, I want people to be aware of what to look for. Superficial spreading melanoma is the most common type we see, tends to present with those classic asymmetry, border irregularity, color change, diameter, and now elevation or changing, evolving ABCDE phenomenon. It's the most common type of melanoma that we see in younger age individuals between the age of 30 and 50. And so this is really the classic type of melanoma we see. Nodular melanoma is listed as the second most common type of melanoma, and it, unlike superficial spreading and other conventional melanoma subtypes, tends to occur or grow over weeks to months. So it's a rapidly growing, high growth kinetic related skin melanoma. I kind of equate this to the uveal melanoma of the skin. It can be very difficult to detect. I've seen more patients with the Band-Aid sign where they think they have a flu shot or a bug bite that's become infected and not gone away. It tends to be pink. It doesn't often have color. This one happens to have a little bit of bleeding, so it looks brown, but these often have very symmetric borders. They're amelanotic clinically, meaning they're pink and so on. And so this is the melanoma we see that accounts for the thickest melanomas. If we're going to look at melanoma by skin subtype or histologic subtype, it accounts for the thickest melanomas, and other studies have shown that about 40% of our fatal cases of melanoma come from this one subtype. And as a clinician, unfortunately, this is what we see, and this is a recent patient whom I've seen coming in with a large melanoma on the arm. Some of this is delay of diagnosis, access to care, awareness, not really thinking about the impact of this tumor on the skin, but this is a nodular melanoma, and the patient's coming in with bulky lymph node disease that we can feel. So already the horse is way out of the barn, stage 3 melanoma at the outset. Lentigo maligna melanoma is an increasingly common type of melanoma. We're seeing this in more sun-damaged sites in an aging population with fair skin. This is going to be the type that occurs on the face, the hands, the ears, the scalp in general. Tends to have a flat precursor lesion that grows over many years, a very banal lesion over time that sort of changes in color, and eventually, and this does not happen in all cases, the progression rates are estimated to be relatively low, but eventually can develop sort of a nodular component clinically that equates to invasiveness in the skin. Acral lentiginous melanoma is the melanoma we see in a small percentage of whites, but much larger percentage of darker skin individuals, simply because they are at lower risk for sun-related melanomas. It occurs most commonly on the sole. These can be similar to treat for some of the skip areas we see in the lentigo maligna type. But this is, again, what we're seeing with a lot of patients coming in, darker skin individuals who may not be aware of any melanoma risk. A non-healing area, they stepped on a rock, they had a sore, they've been treated for months or years for an infectious process. Same thing, we'll see someone being treated for fungal infection of the nails. And so again, increasing awareness is important in these patients. This is a slide that is very recent, just from 2016, looking at cancer statistics and the way people present with skin melanoma in terms of, or cutaneous melanoma, in terms of their stage of presentation, whether it's localized to the skin, regional involving regional lymph nodes, or distant disease at other sites of the body. So most Caucasians and all races, and Caucasians make up the majority of individuals getting melanoma, will present with localized disease alone. But what we see in darker skin individuals, and this is particularly in African Americans, is a fair number of individuals presenting with regional disease of the lymph nodes as well as distant disease. And again, we've got to do what we can from an educational standpoint and an access standpoint to change that. I'll just mention subungual melanoma. This is a variant of the acral lentiginous type. This is a nice one that we would all biopsy and suspect for melanoma. It's got this sort of bleeding of pigment or extension of pigment into the proximal and lateral nail folds. These present challenges with surgery in terms of need to amputate. We don't have good ways to get good margins on fingers and toes, but we're trying to do more digit-sparing surgery. We have other unclassified melanoma types and rare variants, and I just want to mention desmoplastic melanoma because I'm not sure who can see the obvious melanoma here. This is an amelanotic flesh-colored plaque over this gentleman's nasal bridge, and this is the desmoplastic type, which we are seeing more commonly in older age men, particularly on the head and neck areas and sites of chronic sun exposure. Very difficult to diagnose early from a clinical standpoint, harder to look at under the microscope as well, kind of behaves more like a skin sarcoma. Now, just to talk a little bit about skin cancer staging, we look at this as with other cancers with the tumor node and metastasis. The tumor thickness, the Breslow thickness, is the key factor for how we look at how melanoma does. We add in other factors like ulceration. Mitotic rate, while not used for staging, is a key prognostic factor to tell us, again, that growth kinetics of the tumor as well and its prognostic impact. The nodal classification is critical. Melanoma is a lymph node seeking disease. It tends to spread to the local lymph nodes, the local regional lymph nodes, before it goes anywhere. So we pay attention to the number of involved nodes and the burden of tumor within those nodes, whether they're diagnosed microscopically via the sentinel lymph node biopsy, or if that patient who comes in macroscopically, the patient's going to have a worse prognosis. We also take a look then at metastasis, and again, for melanoma, these are not liver predominant. These certainly can involve the liver, but we see lungs, liver, other sites of the viscera, skeleton, and brain, unlike ocular melanoma. So a more widespread look at where metastasis occur at distant sites. The primary treatment for melanoma is surgery, and we've seen the margins evolve dramatically for skin melanoma over time. Melanoma in situ, we tend to take very thin margins. Invasive melanoma, we take deeper and wider margins, and that's been shown with randomized controlled trials data over several decades. However, taking a big margin over 2 centimeters around a skin melanoma does not improve overall survival, local recurrence rates, or disease-free survival. So we've actually found the maximum amount of tissue we need to take around tumors. I'll just mention the sentinel node biopsy. This is the key factor where we inject. This has been around now for 20 years, well established worldwide as an important prognostic factor for disease recurrence and overall survival. So we inject a very safe radioactive dye around the melanoma site. That's done in nuclear medicine the day of the surgery. It travels to the lymph node basin or basins to which that melanoma would drain if it were to spread, and we use preoperative lymphoscintigraphy by our nuclear medicine doctors to identify those areas. When the patient goes to the operating room, the surgeon also injects a blue, isosulfan blue or green dye around the primary tumor site, and then uses what is like a Geiger counter. It's a gamma probe that will pick up those levels of radioactivity within the node, and then we are able to harvest this relevant node or lymph nodes in the basin, and our dermatopathology colleagues look at these very carefully with suctioning through them, and then also looking at immunostains to identify the tumor, and it's a microscopic tumor. The sentinel node status is a key factor for how patients do. Patients with sentinel node positivity will do much worse in general than those with sentinel node negativity. And so we tend to upstage patients with skin melanoma. About 15 to 20% who are lymph node negative will be upstaged from either a clinical stage 1 or 2 to a stage 3 at diagnosis. This allows us then to offer adjuvant therapies. We traditionally were offering more surgery. Offering was kind of the recommended term for the completion node dissection, though that has now fallen out of favor. So we're doing less surgery, as randomized controlled trials in the last year have not shown a survival benefit for doing that extra lymph node surgery, which has long-term morbidity, long-term complications of limb swelling, and so on. We now have some very helpful and hopeful data with adjuvant therapies for melanoma. Our traditional therapy after someone had lymph node disease that was resected, or disease even inside the body that was removed surgically, would have been high-dose interferon, and it's had a lot of controversy with lots of immune-related toxicities and side effects and very little survival benefit proven, maybe just delaying the time for disease to come back. What's new in adjuvant therapy would be high-dose ipilimumab. So again, one of the checkpoint inhibitors that was the first one that was studied and approved for cutaneous melanoma back in 2011. In a study done in Europe, a very high dose of this, given 3 times higher and 3 times longer than we would give for disease all over the body. I'm sorry, I have to say, actually I don't have 2 minutes, I have 15, so I started at 11. Yeah, so, sorry. I started a half an hour late, so yeah, okay. We'll just let that go. Thanks. It's very distracting. 1 minute, 2 minutes, sorry. So I don't want to get through this and give people a chance to ask some questions. But what's very helpful to understand now is that the high-dose ipilimumab, while it was FDA approved a year ago, has had so much immune-related toxicity that we've been loath to use it in practice. And these are patients getting permanent immune-related side effects. We talk about quality of life and survivorship. They have trouble with endocrinopathies, long-term thyroid dysfunction, need to be on replacement. They may need to be on cortisol or cortisone replacement and or testosterone replacement, and also have problems with long-term neuropathy, neuritis. Now we're seeing cardiomyopathy. So we have to be very tuned into how these better therapies work, but also into the quality of life that happens later on. Now, very recently, at the European Society for Medical Oncology, just a month ago, we had 2 adjuvant trial therapies that were presented and also published concurrently in the New England Journal of Medicine. And these have now shown what's called a relapse-free survival benefit in patients with resected stage 3, so lymph node melanoma, and then one of them looked at resected stage 3 and 4 melanoma. One of these combines our common MAP kinase inhibitors, the BRAF inhibitor and the MEK inhibitor together, and the other one looks at nivolumab, which is an alternative to ipilimumab with less toxicity and more efficacy, and that was compared to ipilimumab. And these are very hopeful. They're not yet FDA approved, but we're really hoping that we're going to be able to use these adjuvant therapies to prevent disease from coming back. So metastatic melanoma, just to give you a hint of what's going on, I would say, until now we've had survival rates that were very akin to metastatic uveal melanoma, where we talk about a median survival somewhere between 6 to 10, 6 to 12 months. What's really changed, though, is the bar has moved in the last 5 to 6 years in clinical practice with the newer advent of checkpoint inhibitors that enhance T cell function in the tumor microenvironment or enhance T cell proliferation itself, and also these MAP kinase inhibitors that target particularly the BRAF mutation. We don't yet effectively have a great KIT mutation inhibitor. We don't have a great inhibitor of the NRAS mutation, though that's being looked at. So our changing melanoma treatment landscape, we were left with dacarbazine, DTIC was an old chemotherapeutic standby in the 70s and so on, with very, very little response rates, very, very little success, maybe a 0 to 6% response rate, not lasting. High-dose interleukin-2, we were giving this at Stanford as little as 10 years ago. We finally decided to take this off the table. It's a very toxic regimen. People are admitted to the ICU for the bolus therapy that's given over time, and it cured a very small percentage of patients who were healthy enough to tolerate the therapy. Now we have a slew of treatments, maybe 11 regimens or treatments themselves that have been approved since 2011, with more on the way. And when we take a look at survival, we see single agent, the BRAF inhibitors, the vemurafenib and dabrafenib, having about a 40% overall survival at 2 years. We now combine them routinely with a MEK inhibitor with higher survival, less toxicity. Ipilimumab tends to be used less. It has more immune-related side effects. Instead, we'll use the PD-1 inhibitors, and those are the nivolumab or pembrolizumab with 50% overall survival at 2 years. They can be combined with ipilimumab, again, though, trading for more immune-related side effects. Just to mention, and this will probably be brought up, I'm imagining, later today, and this is a slide courtesy of Kim Margolin at City of Hope, who's working with the group at ASCO on uveal melanoma and so on, and created these slides. But there were very few uveal melanoma patients who were in as part of the original ipilimumab trial. So this is a data looking at those trials that included at least 20 patients or so with uveal melanoma. And unfortunately, it hasn't been the same hit. So we see about 20% overall response for ipilimumab. We're seeing less than 5% with uveal melanoma or so. PD-1 inhibitors, again, a breakthrough in melanoma therapy, less toxic, more efficacious than ipilimumab as a checkpoint inhibitor. Survival is over 50% now at 3 years for the nivolumab alone, and higher a little bit with the nivolumab-ipi combination. And again, with uveal melanoma, some of the earlier trials with PD-1 inhibitors, to my understanding, are showing kind of that same low response rate with about 5%. Now, what's hopeful, though, is that there's a lot more going on with immunotherapy. And so even if we take a look, these are the trials, these will be talked about, I'm sure, in greater detail throughout this conference, but the studies looking at the tumor-infiltrating lymphocytes or adoptive T cell transfer at the NCI are now showing perhaps even 35% plus response rates. And I'll allude to the Immunocore trial that's going to be open very shortly at Stanford and UCSF as another way of enhancing the immune system to really fight tumors. So in conclusions, obviously uveal melanoma has unique biology, and it's a subset of melanoma that requires kind of different therapeutic considerations compared to cutaneous disease. And the emerging insights into biology, particularly genetic mutations, have now led to the development of novel immunological and targeted therapies that hold promise. And clearly, as we say with cutaneous melanoma, patient participation in clinical trials, whether in the adjuvant setting or for widespread metastasis, remains the standard of care and will help to develop effective therapies for this challenging disease. I was asked to mention the clinical trials that we have at Stanford, or will have, opening shortly. This is on behalf of my colleague, our medical oncologist, Dr. Sunil Reddy, who's getting married today. So he's having a 500-person wedding near the airport. So he apologizes for not being here. I do want to mention that our fabulous clinical trials coordinator, Fong Pham, is outside at a table, and she will be happy to talk to you about the available trials. And I have one slide that will also list the single trial that I'm aware of at CPMC. One of our trials will be the DELCATH studies that's being referred to, but this is an open-label randomized phase 3 study of safety and efficacy of the chemotherapeutic agent melphalan through the hepatic delivery system called DELCATH versus best alternative care in patients with hepatic dominant ocular melanoma, meaning uveal melanoma that's metastasized to the liver. The second study is about to open at Stanford and at UCSF, from my knowledge, and I would, of course, welcome Dr. D'Amato telling us what else is going on at UCSF in terms of trials. But phase 2 study looking at the safety and efficacy of this new Immunocore agent. It's a GP100. It has to be in HLA-A2 positive patients. That gets confusing, but it limits who we can use the treatment in. And this has to also be used as a first-line treatment in patients, so untreated uveal melanoma. I don't know if I should bother to go to any of the DELCATH slides. Dr. Ferries is going to speak after me, but everyone, I think, is aware that liver metastasis are a significant cause of morbidity and mortality in patients with uveal melanoma. Surgical resection was at least regarded as a standard of care, but it's a difficult prospect, and less than 10% of patients are eligible for the treatment, with recurrence in the liver being not uncommon. The current surgical and local treatments are often not optimal due to microscopic disease or occult disease elsewhere in the liver, or to bulky nodal disease. And so this has led to the development of now more regional liver-directed therapy. The liver and liver tumors sort of benefit, if you have to look at a positive lining, from being sort of fed solely by the hepatic artery compared to normal hepatocytes, which are nourished by the portal vein. And so if we can direct a chemotherapeutic agent or other treatment into the hepatic artery, which can get directly into tumors at a higher dose, and then filter out that toxic chemotherapeutic agent before it reaches other parts of the body and causes systemic toxicity, that would be optimal. And that's really the goal of the DELCATH study. This will be conducted at 30 centers in the US and the EU, approximately 240 patients, at least half of whom will be enrolled in the US. And a prior phase 2 study, this was alluded to earlier, did show a liver response of 75%, median duration of 13 months, median survival in the melanoma cohort in this liver-directed therapy of 22.5 months. I won't go through the eligibility criteria. You can talk to FAM, and I'm sure this is going to be talked about in more detail. But just to think about this, you're isolating the hepatic blood flow, infusing melphalan directly into the liver via the hepatic artery. You're filtering extracorporeally, so you can see this filter device is outside the body. You'll filter that blood from the liver to reduce the melphalan that returns to the blood, then to the systemic circulation, to reduce the exposure of the rest of the body to the agent. And it requires a huge team. It's taken, I don't know how long, a year to get this going, probably, Prithvi, at Stanford. So it's a lot of work to get it going. We're excited to have it open. Immunocore, I'll just mention, again, very exciting immunotherapy. This is going to look at overall survival, and it's going to evaluate safety and efficacy of this drug against investigators' choice, which would include dacarbazine, Ipi, or Pembro as a first-line setting. 30 sites in the following countries enrolled 2-to-1 in favor of the experimental drug, the IMC GP100. And just to say what this is in minimal detail, it's a bispecific protein. It's manufactured in E. coli. That's kind of a gut bacteria. It redirects T cells against this GP100 melanoma-specific antigen. So it targets that portion, it binds to it on the surface of melanoma cells, and then by doing so, it activates T cells. And T cells are what we use to sort of kill cancer and all the checkpoint inhibitors. And so it actually will induce the full repertoire of cytotoxic T lymphocytes when combined with target melanoma cells. And the first in-human clinical trial did show preliminary efficacy in advanced melanoma. So we're very pleased to have this trial opening up shortly at Stanford and as well at UCSF. I'll skip through the study overview and the inclusion criteria. And again, our trials coordinator, FAM, would be very happy to talk to anyone about this. Other trials that I'm aware of in the Bay Area would include the CPMC trial in the city. I don't know if Kevin Kim is going to come and talk about this at all, but this is now taking advantage of this potential synergy that we see between radiation therapy and immunotherapy. In cutaneous melanoma that's metastatic, we're now using directed radiation therapy along with checkpoint inhibitors, Nivo-Ipi. We tried it with Ipi as well. We've done this in conjunction with Sloan Kettering because we may have what's called an abscopal effect. We're able to enhance that T cell activity by adding radiation. So this is going to look at the safety and tolerability of internal radiation with yttrium-90 along with immunotherapy with ipilimumab and nivolumab, the checkpoint inhibitors, in patients with uveal melanoma metastatic to the liver. So again, we got the notice on this trial just a few months ago, which I forwarded to Prithvi and Sunil. So I'm delighted that there are trials going on in the Bay Area. And like cutaneous melanoma, I hope that some of these are home runs. Thank you for your time. I have to leave at noon, but I can answer questions outside or up here if you want to give 5 more minutes. It's up to you guys. So, thank you.